Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm speaking to Dr. Nada Khan, who is a GP in Exeter and a clinical lecturer in general practice, about her recent study on GP retention. In this conversation, Nada explains how workload has become increasingly intense, fragmented and risk-laden, and she describes the impact of hybrid access models and moral distress on GPs, all of which are causing experienced doctors to cut back on sessions they work or leave the profession altogether. Nada also highlights the critical factors that help GPs stay in practice, including the importance of continuity of care, supportive practice teams, and establishing clear workload boundaries. And we discuss what national policymakers need to understand to address the retention crisis among mid to late career GPs, and the practical changes individual practices can make to support their staff. MIMS Learning Live South is returning to London on Friday the 12th of June, and this year we're pleased to announce that tickets are free to book. This is the event you won't want to miss. It's your chance to boost your clinical know-how, connect with peers from across the UK and gain fresh insights that can make a real difference in your patients' lives. This year's clinical programme covers issues including obesity management, paediatrics, women's health and cardiology. We'll also be running a GP Business Hub stream aimed at GP partners, practice managers and PCN managers, which will be chaired by me. Sessions in that stream will cover practice finance, neighbourhood working, using AI in practice and how to meet the challenges of rising patient demand. Spots will go faster, don't wait. Head to mimslearninglive.com/south and grab your tickets today. And if you come along, do pop over to say hello if you see me. I'm really pleased to be joined on the podcast now by Dr. Nada Khan, who is a GP in Exeter and a clinical lecturer in general practice at the University of Exeter. Her research interests are around the GP workforce and continuity of care and how to enhance the general practice experience for patients and clinicians. And she's here today to talk about a recent study that was published in the British Journal of General Practice about GP retention. Thanks so much for coming on the podcast, Nada.
It's really lovely to meet you, Emma. Thank you.
We're talking about this study you've recently published about GP retention, and this latest piece of research, this followed on from a previous study that explored why GPs leave the profession. So can you explain a bit about that first study to begin with? How did that work and what did that first study find?
So the original study, the regroup study, looked at why GPs were thinking about leaving practice, and that was done back in 2016. And it found that things like workload, stress, bureaucracy, and things like that were major drivers pushing GPs towards reducing sessions or leaving altogether. But what's interesting is looking back is that study captured a moment just before some really major changes that, as we all know, have happened in general practice. So it was pre-pandemic, it was before the rapid expansion of digital first access and total triage, the increasing multidisciplinary team in practice, and before a lot of the current pressures around workload transfer and some of the fragmented systems that we deal with in today's general practice. So that gave us a really good baseline for understanding what's changed since then, but also going back and thinking about why GPs are leaving practice now.
So it's interesting when you say it like that, it just makes you realise how much has changed, hasn't it, over the last 5, 6, 7 years. This recent study, why did you decide to do this one? What had changed that prompted you to look at that group of GPs? Was it just because of all those changes we were talking about then?
Yeah, absolutely. So we really wanted to understand what had changed in the years since that original study in 2016. And as we've discussed, particularly because general practice has changed so dramatically in that time, we know that there's a huge transformation in how care is delivered with online consulting, hybrid access models, and that growing pressure across the wider NHS. And I think at the same time, alongside all that, we continued to hear concerns about GP retention, and particularly amongst experienced clinicians, which is the group of GPs that we were focusing on. And what felt important in this study was not just asking whether workload had increased, because I think we have a sense of that already, but exploring whether the actual experience of being a GP had changed. And we were looking really at how these experienced GPs were making decisions about staying or stepping back or leaving altogether in the context of today's general practice.
And so how did the study work? How did you actually undertake the study? What did you do?
We went back to the group of GPs who took part in the original regroup studies, and we interviewed 19 of them. And they were GPs who were at different career stages and in different roles, including partners, salary GPs, and portfolio GPs. So we wanted to get a good spread of different types of roles and different lengths of experience and practice as well. And we used these in-depth interviews rather than a survey or sort of looking at numbers or statistics because we want to get past those headline numbers about retention and really deep down understand how people were experiencing their work. And this gave us a chance to really explore things like workload, continuity, professional identity as well, alongside those career intentions.
Can you summarise what the study found?
The biggest finding really was that this is not just about workload volume anymore. It's not just about the amount of work, but GPs described work becoming more intense, but also more fragmented and worryingly also more risk-laden. So people were practicing with a higher level of risk. People talked about things like relentless duty days, increasingly complex consultations, more admin work, and because of delays in secondary care referrals, holding more responsibility across those gaps in the system, and especially where workload transfer were involved. So those are some of the challenges, but what the study also highlighted was what helped people stay in practice as well. So continuity of care, which is an area of research that I'm interested in, was incredibly important. But so were things like supportive teams in practice, having really clear workload boundaries, and on the ground good practice leadership, and having some control over how that work was organized. Overall, the results showed that retention depended not just on reducing that pressure of workload, but on the conditions that actually allow GPs to practice in a way that feels safe and meaningful as well for them as professionals.
It's interesting, isn't it? I talk to GPs quite a lot, actually. And one of the things that when I've spoken to people recently, a lot of people say that it's really complex now being a GP. The clinical work itself is actually quite complex. Like I've spoken to experienced GPs that say sometimes that there's not a week goes by that they don't have something that challenges them to the kind of limit of their clinical knowledge. Is that something that you found as well in your study?
Yeah, it was that increasing complexity of the consultations that people are dealing with. So increased issues around mental health or multimorbidity,
Yeah.
and holding that as well because there aren't the systems to support those people outside of general practice. So often GPs felt that they were responsible for that sort of clinical care.
You mentioned the admin burdens, but also, that transfer of work from secondary care. How did the GPs you interviewed describe the impact of this sort of unfunded work, which we see a lot being transferred from secondary care to primary care? How did they manage that and how did it impact on their mental well-being?
This highlights just how much invisible work GPs are doing around consultations. So people described huge amounts of work coordinating appointments and referrals, following up on test results, and navigating different referral systems. Another thing that really came up was how GPs were responding to things like advice and guidance requests, and picking up work that was generated somewhere else in the system that was being sort of offloaded back onto them. Unfortunately, for the GPs that I spoke to, a lot of this work happened outside of their booked clinical time or sessions, and often without additional resources. It's a volume of workload, but it's also a cognitive and emotional load that GPs are carrying. So people were developing this sense of sort of constant responsibility and vigilance as well, because they were worrying about missing results or delayed care of the patients that they were looking after falling through these gaps in the system. And I think that really impacted on the GP's well-being as well, and how much they felt that they could stay in their roles.
A key theme is moral distress, isn't it? That's something that people have started talking about more in the NHS really since the pandemic. But what does that look like for a GP and how is it different from burnout?
So yeah, you're right. Moral distress is this idea that's really coming through now in general practice and the pressures that people are working in. And I think that for the GPs, especially in this study, it was that feeling of knowing and envisaging what good care should look like, but not being able to actually consistently provide it because of the conditions they're working in.
Yeah.
So people talked about the loss of continuity, and they often felt that they were working in ways that were transactional and not kind of that relationship-based care that they wanted to provide. And I think that's slightly different from burnout, which is more like kind of just exhaustion and being depleted. But I think this moral distress is that sort of mismatch between having these professional values of how you want to practice as a GP and actually the realities of what's happening on the ground.
You've mentioned a couple of times as well, like sort of the change in the way people access general practice and digital online consultations, digital triage tools. Obviously, the government policymakers are really quick to promote these things because they think it's going to help demand and help people get access to a GP quicker. But your findings suggest that hybrid access models involving all these forms of contact have actually intensified strain for doctors. Why is that?
Yeah, I think that's really interesting. And I think you're right. There is this assumption that digital access would streamline demand or make consulting more efficient. But some of the GPs I spoke to described exactly the opposite. So, a lot like that invisible work that I was talking about, instead of replacing other types of contact, these digital systems kind of added extra layers. So, someone might submit an e-consultation, but then need a phone call, which actually then you speak to them and you think, oh, right, well, I need to bring them in for a face-to-face appointment. And then there's the background admin work sort of generated at each stage. And GPs describe this as kind of like fragmented consulting. So you're constantly switching between different tasks and modes of communication. And that can sometimes increase that cognitive load as well. Again, that sort of way of practicing that some people valued in sort of traditional consulting models as well.
You've talked about continuity a bit and how important that is for GPs and them wanting to stay. I mean, I suppose just talking about that then, the digital stuff, that stuff wouldn't be so burdensome if it was continuity, if it was patients you knew and stuff, but moving between those different models perhaps would be less stressful. But, given access has been such a focus in general practice in recent years, and that looks like really set to continue, what would you say to policymakers about that when you sort of realise that continuity is so important to GP retention?
Yeah, I think unfortunately the way that things are set out often in terms of this sort of access versus continuity debate, they're set at opposite ends of a spectrum that, if you're offering continuity, you can't offer good access. And I think a lot of research coming out from Manchester, Jennifer Voorhees has done some work around this, is that actually offering better continuity can improve access. And for the GPs we interviewed, continuity wasn't sort of a luxury or optional extra. It was actually central to what made general practice meaningful and clinically manageable for them and their patients. And this is because when you know patients over time, consultations are safer, they're much more efficient, they're more satisfying. People are less likely to come back for repeated consultations, for instance, and it's often quicker to get things done when you know a patient well. That reduces that complexity that we've talked about that's making current general practice so challenging, and sometimes can also reduce that uncertainty and risk that I think we're increasingly carrying in practice as well.
That makes sense, doesn't it, really? It's less of the worry as well. If it's someone you kind of know when things are sort of, you've got a gut feeling to a certain extent, haven't you, whether things are right or wrong. Whereas if it's someone you don't know at all, then the concern about whether they could deteriorate is probably a lot higher.
Absolutely. And I think that's that sort of innate knowledge that you carry when you've built a relationship based on trust and knowing each other. And patients often feel that as well. So they might feel more able to discuss things with their GP as well. So I think it reduces that risk. And I think if policy just continues to focus purely on rapid access without protecting continuity, we can undermine those values as well.
One of the other things, obviously, you found in your study, and this is just true generally, isn't it, is that many GPs have moved to portfolio working as a way to prevent burnout and keep working longer. I mean, obviously, what that means is they're potentially cutting back on sessions in frontline general practice. But that obviously has a wider impact, doesn't it, in terms of loss of experienced GP hours on the front line. We are losing GP time even from those who remain in general practice, aren't we, effectively?
That's probably one of the really important findings here, because these really super experienced GPs who have lots of knowledge about clinical work weren't necessarily leaving medicine altogether, but they were reducing their clinical sessions, which is where they felt that cognitive overload, really. They're stepping back from things like duty work. So technically, although they're remaining in the workforce, the system is still losing their frontline clinical capacity and knowledge. These experienced GPs are really the backbone, I think, of general practice. They carry that continuity with their patients, supervision, mentoring, and that sort of organizational knowledge. So I think it's really important to make sure that that experience and expertise remains available to patients and teams on the ground.
Did you look at the difference between partners and non-partners? Did you find like GPs stepping back from partnership roles? Because obviously that's something that is kind of reflected in the workforce data, that the number of GPs who are partners is falling quite rapidly. And, what are the implications of that?
One of the positives that some of the GP partners that I spoke to mentioned was this idea of being able to craft their role and their practice as well. So when things weren't working, like triage or appointment systems, GP partners actually had that ability to shape things. So the systems within the practice, so they could redesign the triage system or set workload boundaries and really influence how things were working on the ground. And that gave them that sense of control that really helped make work feel more sustainable. But I think some non-partner GPs, they described having less control over how the work was structured. So they were a bit more exposed to these intense clinical sessions, didn't really have that sort of agency to redesign the systems. And although I think partners had that agency to do something, sometimes there were pressures outside of the system that they couldn't really change, and they found that really difficult. So partners are stepping back because of things like financial risk or the responsibility in holding their practice together during some really pressurized times and with reduced funding in general practice as well.
That's the thing that kind of comes through from lots of people I hear talking about partnership. You kind of mentioned some of the things that could keep GPs in the workforce. And one of the things that you sort of touched on there is that GPs who stay often have clear workload boundaries. So what do those boundaries look like in practice?
These boundaries were really often pretty practical. So GPs talked about things like capping duty lists, protecting their admin times, having realistic appointment numbers and time for appointments, and some of the systems that can reduce interruptions during the day. Some of the practical things follow things like BMA best practices for how we should be working on the ground. A lot of this is about scheduling, but I think it's kind of this feeling that work should have some kind of limit contained. So there's a system to make sure that workload isn't just endlessly expanding, which can sometimes feel really unsafe or too much when you don't feel like there's a really clear endpoint to the day. I think that came through quite strongly in the interviews that we did.
Did you find that places that had followed those BMA workload limits, were people finding general practice more sustainable as a career when they had followed those?
Oh, yeah, absolutely. I think that I spoke to a few GPs where there were these clear systems in place and people had 15-minute appointments where they had capped duty lists and they were feeling that they were thriving, and they described how well they thought their practice was run, especially because some of these GPs had worked in practices which weren't able to run that way. And I think stepping back and working in places where the systems were capped and following safe working guidelines really made a difference to their working day and being able to leave at the end of a session thinking, okay, I've done my job, it's done, and feeling satisfied in their work.
Most governments sort of pull away from that because they think it's going to impact on access of all things. They think it's going to restrict access. But obviously, if things like that help keep GPs in the workforce for longer, that's probably a benefit for everybody. So would you say that policymakers should be thinking more about these sorts of issues, like how to limit workload in general practice and how to help cut the number of consultations GPs have to do every day?
Yeah, I mean, I can completely understand the tension from a government perspective because what they want to see is appointment numbers rising. And that's the kind of data that makes it look good in general practice. Sort of, we see that, how many million of appointments are delivered in general practice. And if you look at the GP appointment data, actually the number of appointments are always increasing. So I think we are hitting those targets. But I think on the day, there has to be an understanding that it's unsafe to actually work without limits. If you've got a duty list that's got 70 to 80 contacts in a session, there's no way that you can effectively and safely triage and deal with each patient safely. And I think that that's what governments really need to think about, is that it's not just about numbers. It's about working safely for GPs and for patients as well, and not thinking about capping numbers can actually really influence that safety on the ground as well.
This study's come out at a time when the workforce is actually growing overall. So I suppose there's a danger there, isn't it, that governments could look at that and think, oh, it's all okay, number of GPs are going up, and not pay attention to this kind of retention crisis with older, more experienced GPs. Why is it important that they look at that and they pay attention to this particular cohort of doctors?
I absolutely agree. There's definitely that risk because those headline workforce numbers don't really reflect what's happening within this experienced GP workforce. That's so important for management, for supervision, for clinical experience. As we've talked about, our study highlighted that a lot of these experienced GPs are not necessarily leaving medicine entirely, so they're still staying in those workforce numbers, but they're reducing sessions or stepping back from duty work or moving into these portfolio roles. So I think technically you can probably grow workforce numbers while still losing these experienced sort of frontline GPs. And like I said, losing that experience has consequences not just for access, but for that quality and safety in a practice and that management of actually the wider functioning of teams. And I think increasingly with this move towards neighborhood working or moving care into the community, it's going to be these experienced GPs who are going to drive this forward. It's really important to make sure that they feel supported in practice.
That's a really good point, isn't it? I mean, it's quite hard to see how you could do any of this stuff without having really experienced GPs there. Based on the findings of this study, what would you say is the most significant intervention the government or NHS England could make to stop this exodus of mid to late career GPs?
Going back to what we were saying, I think one of the main things is restoring that sense for GPs that work is containable and professionally sustainable. So it's not just about reducing the volume, but it's about thinking about how to reduce fragmentation and creating those systems where GPs feel that they can practice safely and well and be that good GP that they want to be. So going back to what we were saying, I think if I had to pick out one key thing that the government could do, it would probably be creating these credible workload boundaries. I think in our study, many GPs describe that feeling that demand and responsibility have become limitless, and especially on duty days. And without that sense of containment, it becomes really hard to think about sustaining that long-term career in frontline practice, especially since a lot of practices are moving towards that initial triage system as well in practice.
When you did the study, were we at the point where we were doing all-day online consultations? What was the kind of thoughts about that? Did people feel that had driven workload out of control?
I think it was chipping away at that sense of being able to offer good professional general practice care. And people felt that a lot of times it had opened up access in a different way. So people were accessing them for things that potentially they didn't need to be coming to general practice for. So it was easy to shoot off an e-consultation for something that didn't necessarily need to be done in practice. So some GPs described that as a bit of an issue in terms of how they felt that they could provide good quality of practice as well.
Is there anything else, like talking at a national level that the government could do aside from those workload limits? Is there anything else you kind of came across which you think they should be doing?
The NHS and general practice, it's a really complex system. And often I think about the thing that when you make a change to a complex system, you're going to have lots of complex outcomes as well. So I think that there just needs to be a lot more attention to some of these unintended consequences of system design. And as we've talked about, a lot of policy focuses on access and getting patients appointments, but actually a lot less on what the work feels like to do or how it feels if you're a patient as well in terms of quality of care. So it's not great for a patient either, having issues around workload transfer from secondary care, waiting for referrals to come through and not being able to get a referral because we're being pushed to advice and guidance instead. And those fragmented pathways that both GPs and patients are experiencing, alongside some of the issues around workload boundaries, I think there's a real need to protect continuity of care more explicitly. It's really good for patients. We know that it improves outcomes for them. But in this study, it's one of the things that made the work feel much more meaningful for GPs as well.
From what you found, is there anything practices can do themselves to make their working environment better for their GPs? I mean, is it things just like workload limits and continuity, or is there anything else they could do?
I think some of the GPs who described that those really sustainable environments talked about how the practice systems worked well. So some practices had redesigned triage or duty systems in ways that reduced intensity. For instance, one GP was telling me how on the triage day, GPs and admin staff all sat together and they were able to discuss the incoming requests or e-consultations. So they had a really clear system of working together to make sure that appointments were being distributed across the multidisciplinary team appropriately. Again, that sort of thing improves access because patients get the right sort of care for what they need. And I think that those clearer boundaries around work really helped as well. So practices that had set aside blocks for admin time, for instance, that really helped. Some GPs described having a task list, which was almost like a mini session, a mini clinic in itself. So they needed time to really do that appropriately and safely as well. So I think these really small operational changes can have a really big impact on whether people feel either in control or completely overwhelmed, which is not a good place to be.
How did those admin things work? Is that just like extra time built onto the end of sessions and that just for people to do admin?
Yeah, absolutely. So instead of having sort of potentially more sort of triage appointments or anything, just having a block that was admin.
Yeah.
Another thing that worked really well for practices was having a daily clinical meeting. So making sure that everybody was coming together in the practice to have a chance to discuss what was going on and sort of catch up on where the pressures were as well.
And the sort of sitting together to do the triage, that's basically, some of that stuff is just about basically not feeling like you're on your own,
Yeah.
battling against it all, because that can be what causes a lot of stress to people if you just feel like you're battling against a never-ending workload all on your own.
Yeah. And also that feeling where you might be a little bit uncertain or holding that risk and you just want somebody to talk it through with. It helps receptionists as well. So research has shown that having that sort of co-location working works really well, it's especially for reception teams as well, in terms of increasing their feeling that they're doing the right thing and people are being triaged in the most effective way.
Because that's a really stressful and demanding job as well, isn't it?
Yeah.
For GPs who are listening to this who may feel, they're currently at the tipping point and finding it all very stressful, what was the most sort of hopeful or encouraging thing that you heard from the doctors who managed to find a way to stay?
Probably that a lot of GPs really genuinely loved the core of the work that they did. Some GPs described being really proud that they were providing good care to a small patch of, where their practice covered, and that was really meaningful for them. So I think people spoke really powerfully about those relationships with their patients and the privilege of when they had good continuity of being involved in people's lives over time as well. And that gave them a real sense of meaning. And I think that goes back to the study findings about what helped people stay was finding ways to reconnect with those really meaningful parts of the role, if it could mean portfolio working or better boundaries. But the hopeful thing was that a lot of people were finding ways to adapt without losing their identity for being a GP.
We're supposed to be getting a new workforce plan, and the RCGP, the Royal College of GPs, very critical of the last workforce plan under the Conservative government because they felt, and lots of GPs felt, there wasn't enough in there about retention. Do you hope that the next workforce plan will actually take steps to address retention as much as recruitment?
Absolutely. I think that this study has shown why it's so key that we retain these experienced GPs. And there were ways that we were able to retain GPs, for instance, with sort of those return to work schemes. A lot of those have vanished over time with the lack of funding.
Yeah.
But I think it's not just going to be about having these sorts of schemes in place. It's going to be about addressing the wider systemic issues about what it feels like to work in the NHS. And it's probably not just a problem for general practice, but probably sort of more widespread as well. But I think there has to be some serious thought into thinking about what makes general practice a safe and meaningful career for people to stay in, because that loss of GPs over time is going to hugely impact patient care over time and what the NHS can safely deliver, especially with this increasing shift into community and prevention. So GPs have to be at the forefront of that.
Yeah, absolutely. And I think especially, like I've talked to people about this quite a bit about, we live in a time with an ageing population, multi-morbidity, like you said, multiple long-term conditions. You need like generalists and GPs to help manage that change in the way society's going, don't you?
Absolutely. And those sorts of things go alongside continuity. So
Yes.
GPs who are able to look after their patients, their complex needs over time, have that real understanding of what patients need, how to care for them efficiently and effectively. That's going to make a big difference, I think, in that aging multi-morbid population that we're working with. I think that this group of experienced GPs really are the backbone of general practice. So I just hope that, we think about ways to keep them in practice. And the paper itself goes into a bit more detail about sort of practice level interventions that we suggest from coming out of the work, but also system level and policy level actions. So if anyone's interested in looking at that, just go find the paper on the BJGP website and have a good look through. Just at the end, there's a table that summarizes some of the things that we think could be put in practice.
We'll put a link to that in the notes of this episode. That's brilliant. Thank you so much, Nada, for speaking to me today. It's been really great to talk to you.
Yeah, thanks very much, Emma. It's lovely to chat about the paper.
Well, that's it for this week. Thanks for listening, and thanks again to Nada for speaking with me. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news and access lots of other resources on our website at GPonline.com.